Bismillahirrahmanirrahim. Over to Professor Rashid Saab for the recitation of Holy Quran.
Bismillahirrahmanirrahim. Fazkuruni azkurkum washkuruli wala takfurun. Fazkuruni azkurkum washkuruli wala takfurun. يا أيها الذين آمنوا استعينوا بالصبر والصلاة إن الله مع الصابرين. शुरू अल्लाह के नाम से जो निहायत मेहरबान रहम वाला है, और तुम्हें वो बातें सिखाता है जो तुम नहीं जानते थे, लिहाजा मुझे याद करो, मैं तुम्हें याद रखूंगा, और मेरा शुक्र अदा करो और मेरी नाशुक्री ना करो। ए ईमान वालो, सब्र और नमाज से मदद हासिल करो, बेशक अल्लाह सब्र करने वालों के साथ है। सदक़ल्लाहुल अज़ीम।
जज़ाकल्लाह प्रोफेसर राशिद साहब, आपका हमारे साथ बड़ा अरसे से सफ़र है और 2021 से वो स्टार्टेड दिस जर्नी विद द हेल्प ऑफ प्रोफेसर Salma Kundi. Thank you so much, Professor Saira, Salma Kundi, for you are always input as educational leader. और आप शायद ना होते तो मैं इस सफ़र को शायद ही कहीं कब का छोड़ चुका होता। और फिर इसके बाद इसको वो स्टार्टेड, और उसके बाद हमारे साथ साउथ एशियन एसोसिएशन ऑफ फिजियोलॉजिस्ट भी मिल गया, फिर पाकिस्तान एसोसिएशन ऑफ पैथोलॉजिस्ट भी हम हमारे सफ़र में शरीक हो गए। वुमेन मेडिकल एंड डेंटल कॉलेज तो पहले हमारे लीडरों में से थे, और इसके बाद पिछले साल से वुमेन मेडिकल एसोसिएशन ऑफ पाकिस्तान वो भी हमारे सफ़र में शामिल है। बहुत इंपॉर्टेंट टॉपिक है आज का, साइकोलॉजिकल फर्स्ट एड, और उसके अंदर जो है प्रैक्टिकल गाइड फॉर प्रोफेशनल्स एंड एजुकेटर, स्पेशली मैडम सलमा, वो जो आपकी तरह लीडर हैं और जिनके यहाँ आजकल इश्यूज ज़्यादा आ रहे हैं। तो आई अटेंडेड दिस लास्ट टॉपिक वेबिनार विद प्रोफेसर साइमा रफ़ीक एंड प्रोफेसर साइमा बतूल एंड नाबगा, एंड आई रिक्वेस्टेड कि आप भी हमारे पीएमए के वेबिनार के ऊपर एक इस तरह का वो कर दें। तो प्रोफेसर साइमा रफ़ीक ए वेल नोन मेडिकल एजुकेशनिस्ट भी हैं, बेसिकली तो ये गायनकोलॉजिस्ट हैं, प्रोफेसर ऑफ गायनी हैं, तो चेयर हैं एफडीपी की, यूनिवर्सिटी ऑफ कॉलेज ऑफ मेडिसिन की, यूनिवर्सिटी ऑफ लाहौर की। बड़ा लंबा सफ़र है, बहुत बड़ा नाम है, और ख़ुद मैं अब इनसे खुद सीखता हूँ। जब मैं बैठता हूँ, जब इनकी कोई प्रेजेंटेशन होती है, मैं खुद इसमें से लर्न करता हूँ। प्रोफेसर साइमा बतूल, सेम नाम नकवी, और बुनियादी तौर पे प्रोफेसर ऑफ पीड्स हैं, मेडिकल एजुकेशनिस्ट हैं यूसी एमडी की, और इनके साथ भी नेशनल इंटरनेशनल बहुत सारे मैंने फोरम पे अटेंड किए हैं। प्राउड ऑफ दिस कि मैं भी डॉक्टर साइमा बतूल आप लोगों से सीखता हूँ, क्योंकि सीखने की कोई उम्र नहीं होती। और हमारे
थैंक यू
दरमियान
सर।
एक बहुत ही नौजवान बच्ची, नौजवान स्पीकर, और मेरे क्लास फेलो की बेटी है, एमबीबीएस में मेरे क्लास फेलो थे। तो बड़ा अच्छा मैंने लगा, और माशाल्लाह इनकी तरक्की को देखा, डॉक्टर नाबगा, और इस वक्त ये यूके में है। तो ये इंट्रोडक्शन था, और इससे इसके बाद मैं ये सारी कहानी जो है, ओवर टू प्रोफेसर साइमा रफ़ीक, शुक्रिया के साथ, ओवर टू यू, और
जी सर।
नॉट यू लीड द प्रोग्राम जब तक ये वेबिनार चलेगा, यू आर नाउ लीडर।
चलें ठीक, थैंक यू सर, थैंक यू। So everyone can see the screen?
Yes, yes.
Yes.
जी, Bismillahirrahmanirrahim. Thank you so much, sir and Madam Salma, for having us on this webinar. And I will basically discussing why we need this, why we have to learn psychological first aid. Okay, can you see the date of publication of this article? This is July 2022, exactly roughly 4 years ago, when this person claimed that this would be an epidemic and the Pakistan should be prepared for this epidemic. Why Pakistan should be prepared for this epidemic? Because we have 55% of population that is below the age of 25. These are the stats from 2019. And I will just say, just concentrate on a word, 70%. Approximately 70% of the deaths were between age 15 and 29. Okay, now come to the burden of mental problems. So, 1 in 4 student overall population में 1 in 4 student is in some sort of psychological distress. When we talk about the MBBS profession or health professional education, we are at double risk of suicide as compared to rest of population. And being clinician, we all know, or being involved in MBBS curriculum, most of us, or maybe some of you are involved in education. Just so you can see what are the risk factors. The chronic sleep deprivation, we all know, emotional fatigue, and I personally feel these two factors, which I will now say, the high expectation from family and society, and a perfection culture in medical training, these are actually the two main contributors to burnout, anxiety disorder, depressive symptom, emotional detachment, and then maybe some of the doctors may with end of their life. So let me say this: we train our doctor to treat other, but we do not train them to protect their own mental health. This is an article from postgraduate anxiety rates, and you can say the prevalence of high rates, and we all know the postgraduate trainee, they are actually struggling their lives. And we in that training or so, what we found, as we have been trained in the same setup, same FCPS trainings, that the stress is often normalized as a part of training and is not recognized as health concern. Okay, so let's see, and let's have an idea what are the primary stress drivers. Yes, academic pressure. Have you ever seen the list for MD-CAT students? Have you ever seen the list where the merit for KE closed? And it's honestly in public sector, the merit close for the medical college of even DG Khan at 90%. So the academic pressure is there. Then there is the prevalence of family disputes or maybe family disagreements also. And the last thing, which will be more common, and I guess you all may agree, that is excessive use of social media. So what this social media is doing to our generation, it's a sort of double-edged sword, in a form that we all need social media to connect. But the overuse of social media do link with mental health problem. So the negative impact include the social media do create a constant comparison or a constant competition. Then obviously some of the forums like LinkedIn or so, they do create do add to the academic pressures. One of our student shared with us that if we look at the LinkedIn profiles on daily basis, I do get stressed. Then doom scrolling is basically when you scroll for the negative comments or a bad news repeatedly, and you keep on scrolling the social media, and this will lead to sleep deprivation. Another thing which I personally feel, that even we as an older generation, or maybe not the Gen Z, we are also suffering from a phobia that is called nomophobia or nomophobia. So no mobile phobia. So this no mobile phobia will compel us to check our mobile again and again, and it will inhibit to our ability to concentrate. This thing we all are familiar, that that we have a culture of silence. We have a fear of labels like loser or sensitive, and we do not seek help for our mental problem. And for PGRs or even for doctors, health work overload. And in that overload for PGRs, we do have some calculation that they should not work for 80 hours or 60 hours. But what about the consultants? Are they being paid at one place that they do not have to rush for the private practices or so? So at times it's a 24-hour practice, and they don't have the time limits. So, what are the pillars of stigma? I personally feel there are four pillars of stigma. One, at the institutional level, we never allowed the faculty even to discuss the problem, or if they are having any mental, you can say, psychological problem, issue, or even a very minor form of anxieties. Then there is social platforms, then self, and then from parental. So when I would be discussing the last slide, one of you, or maybe all of you must be thinking, ऐसा क्या हो गया, हम सभी इसी से गुजरे हैं, हमने भी ऐसी ही ट्रेनिंग की थी, हम भी ऐसे स्ट्रेस होते थे. तो ऐसी अब की जनरेशन को क्या प्रॉब्लम है? प्रॉब्लम ये है कि हमारी जनरेशन was being we were brought up like that the mental health is a taboo or a weakness. We found that the stress is somehow equivalent to endurance, and we have to bear, we have to be patient about the stress or so. But we were lucky enough to have a very strong family support, and we have even the religious support as a coping mechanism. What you may hear from the younger generation, they are more aware of mental health vocabulary. You may find a 6 or 7-year-old kid saying, मुझे डिप्रेशन हो रहा है, मुझे एंजाइटी हो रही है, मैं बोर हो रहा हूँ. You can say the age we do not expect this sort of language from that kids. And then they are more open for anxiety, depression, burnout, and they do have dopamine drain. Dopamine drain is actually, you can say, when you see the screen, there would be release of dopamine, and dopamine gives you some sort of rewarding, or you can say a sort of small win. But repeated or overstimulation with screen will then result in dopamine drain. And then you feel boredom, and you need a reset. You have a reset of your brain for that rewarding mechanism, and you cannot get happiness or so with small activities. Okay, so keeping in mind these differences, we should be very mindful. Yes, this generation is more aware for mental health problem, but they do not cope, and we all know that they are overwhelmed with a constant state of exposure and comparison. So they cannot actually they cannot stand with the mental health problems or even with the small stress. So what can we do? Should we wait for the government to take care of these psychological issues or so? Do we really think that in our setups with the available sources, government can do everything? And the answer, I guess, would be no. We have to do something in our capacity. What we can do with our identity of a teacher, with an identity of a parent, with an identity of a caregiver, because our patients are from the same society. We are looking after the same patient. The burden of PCO, the burden of infertility with the same Gen Z. So what can we do? We can do what is in our hand is actually we can offer help. Seeking help is a sign of strength. Another thing which we can do as you can say that we are a part of MBBS program. As a teacher, what we can offer is that you can facilitate early discussion, reduce stigma around the sensitive label, and create a safe space for expression. And when you are caring or looking after the postgraduate resident, you must be mindful. In addition to the point of MBBS, you should be mindful for their working hour. if they are having any sort of burnout. And I always feel that being involved in clinical training, we are as a role models. So we have to perform a healthy role modeling for work-life balance and self-care practices. And then as a family, yes, allow an open conversation, plus allow the activities that actually help to combat with this dopamine balance, and all the social interaction of physical activities, and a combination of physical activity, social interaction, and then screen time can actually help in regulating this dopamine release, and the student can work. And as then at the level of institution, we personally have witnessed the journey of University of Lahore for having mentoring programs and then well-being programs. So the tag of these well-being programs offer actually liberty for even faculty to attend these training, these activities. They can go there, and we recently have this UL well-being week, and there were we were already discussing, there were very physical sort of activities and painting and etc. That can help to reduce the stress. And then we should have trainings for stress management, and these trainings should be even offered to the non-medical students or so. Another thing, the last, we feel that we as an educators are the first responders. So we should learn how to respond to a stressed student. So that's why this training came in, and we actually learned from Dr. Nabga that what is psychological first aid, and what we as a trainer, we as an educator should learn, or even we should learn as a caregiver. Because the specialty, especially I deal, we do see the patient of infertility, we do see the patient of PCO, we have the girls with difficult weight management. So even at times they are stressed out. So we should learn this. And I personally feel it should be a series of workshop with this training. Then there is another training that is called Question, Persuade, Refer, the QPR training, the same training for suicide prevention as we say CPR. And then obviously, as it's linked to the social media use, then there should be training for effective use of social media, the social this digital professionalism and digital well-being. Okay, with this, over to Dr. Nabga, and she will actually tell us how to do this first aid.
Thank you, Professor Saima Rafiq. Over to you, Dr. Nabga Naqvi.
जी सर.
थोड़ा सा अपना तारुफ करा दें बेटा.
जी सर, बिल्कुल. Yes. Actually, I have changed my laptop and I'm not used to of it.
Do you need any help, Nabga? I can share for you.
All right. I'm all right. Aslam alaikum everyone. Aslam alaikum Dr. Mulazim, Dr. Saima, Dr. Salma Kundi, and Dr. Saima Batul. I'm Nabga Batul Naqvi, and currently I'm working in UK as a special education needs teacher and as a well-being practitioner in a well-known school in UK, which is like related, which typically manages special education needs kids. So ये जो टॉपिक है साइकोलॉजिकल फर्स्ट एड का, जब रिसेंटली लास्ट जब 2 इंसिडेंसेस हुए थे सुसाइड के स्पेसिफिकली पाकिस्तान में, जिसकी बहुत ज़्यादा हाइप क्रिएट हुई थी, और इसके बाद बहुत ज़्यादा वो सोशल मीडिया पे जो है वो उनको दिखाया गया था. एट दैट टाइम me and Dr. Saima we discussed that we need to do like some sort of workshop or some sort of training related to this. So at that time, this idea of psychological first aid like developed. So psychological first aid is basically similar to
नाबगा इसको पावर पॉइंट पे कर लो ना, बट स्लाइड मोड पे कर लें।
जी जी
नाउ इट्स गुड, थैंक यू सो मच।
तो उस वक्त हमने जब बेसिकली साइकोलॉजिकल फर्स्ट एड जो है इट इज सिमिलर टू फर्स्ट एड ट्रेनिंग, जो कि हम लोग जो है वो जब फिजिकल प्रॉब्लम से रिलेटेड जो है वो हम यूज़ करते हैं। लेट्स स्टार्ट। सो आज के हमारे सेशन ऑब्जेक्टिव्स होंगे कि हम लोग साइन ऑफ स्टूडेंट डिस्ट्रेस जो है उसको रिकग्नाइज करेंगे, जो कि डॉक्टर साइमा ने ऑलरेडी जो है बहुत अच्छे तरीके से एक्सप्लेन कर दिया। बेसिक प्रिंसिपल्स ऑफ साइकोलॉजिकल फर्स्ट एड क्या है इनके बारे में डिस्कस करेंगे। सपोर्टिव और कम्युनिकेशन हम कैसे यूज़ कर सकते हैं। Identify the high risk indicators that will definitely require escalation and how we will be escalating students, what pathway we will be using, and signposting students safely and appropriately. I don't know what is happening to this presentation, but I'm not doing anything.
कि आप दोबारा
Please
इसको
share with me. I
दोबारा
will
शेयर
share the
करो।
slide for you.
There we go.
हाँ ठीक है, ठीक है।
Yeah.
नाबिहा नजर आ रहा है, सेशन ऑब्जेक्टिव्स हैं, आप शुरू हो जाएं, बिस्मिल्लाह कर लें।
जी, तो साइकोलॉजिकल फर्स्ट एड क्यों मैटर करती है? As a university staff, as we have discussed before, that teachers will be the first point of contact. For distressed students, many students do not initially seek formal mental health support because, like, due to the fear of stigma, due to the fear of being कि उनका बहुत ज़्यादा मजाक बनाया जाएगा, या फिर ये है कि बहुत ज़्यादा जब आपके स्टूडेंट्स के पास ऑलरेडी स्टडीज़ का बहुत ज़्यादा बर्डन है, सो दे डोंट गेट टाइम टू गेट टू अ साइकोलॉजिस्ट टू अटेंड सेशंस। सो एट दैट टाइम साइकोलॉजिकल फर्स्ट एड जो है वो बहुत ज़्यादा इंपॉर्टेंट होगी। Calm, supportive early response, which can reduce escalation and encourage help seeking. Staffs are not expected to basically provide therapy, but they will be the first responders. So you need not to fix anything, and we will not try to fix anything while doing psychological first aid, but our response matters. High risk indicators when psychological first aid became critical is if the student is saying that I don't want to continue my studies, what is the point of living in this world? Sudden disengagement, if you are seeing the sudden disengagement in your students, that he's being disengaged from the social activities, from classroom, from their normal functioning. And then if there is a mention of self-harm, whether you witness it or whether it is being told by the student or anyone related to it, that times PFA will become critical. PFA क्या है or what PFA is? It's basically immediate psychological support, stabilization, and connection, and then it's not a therapy. what are the main aims of PFA? So same as we do in first aid, that preserve, prevent, and promote. Similar will be the aims of PFA. The first is to preserve life. We're trying to preserve life. We're trying to preserve the quality of life of an individual. And then next is to prevent escalation. प्रॉब्लम एस्केलेट ना करे और उसके जो है वो इंक्रीज ना आए, सो वील बी प्रिवेंटिंग दैट. एंड देन इट्स प्रमोट रिकवरी, providing comfort, and meanwhile we are raising awareness about the mental health issues and that they can be treated and we can manage them. And then last is reduce stigma that Dr. Saima has already discussed really well. What PFA is not. It's not a diagnosis, it's not counseling or therapy, it's not a long-term care, or we can use it for the long-term, we can use it as a long-term treatment plan. It's not pressure to disclose personal details, and it is not trying to solve every problem immediately. The core model, or the model we are going to use for psychological first aid, is look, listen, and link. So first case, look. What are we looking at? We'll be looking at the risk. What are the risk factors of a particular issue? If a student comes to you, or any patient is coming to you and you suspect that he's going through some sort of mental health issue, then what are the risk factors? And what could be the risk? Will it be risking his life? So first case, to look for it. Second is distress level, that will be evident by his or her body language. Facial expressions can help. And third is functioning. So what kind of appearance a particular individual have, like कहीं उसकी जो है वो ड्रेसिंग सेंस में चेंजेस तो नहीं आ गए, उसका जो है वो बिहेवियरल चेंजेस तो नहीं ऑब्जर्व कर रहे हैं आप लोग, क्लास में डिसएंगेज तो नहीं हो रहा क्लासरूम से, और हम कह सकते हैं कि और इफ इट्स अ पेशेंट, तो वो किस तरह की फिजिकल अपीयरेंस के साथ आया आपके पास. The second is listen. What we are listening. Listen without interruption. Don't interrupt the individual when he or she is trying to tell or share his or her problem. Use a calm tone. Reflect emotion. That I'm understanding what you are feeling. I can understand what you are going through. Validate students' experience. How are you going to validate is, I can understand how difficult it is. And next is avoid judgment. Do not judge. Judgment would be like, this has happened to us before. Why are you not able to and next and last is, avoid rushing to the solutions. Immediately do not provide any kind of solution. Just try to listen and then try to support.
उसमें ना वो
Listening to the when you will be listening to your patient or your student at that time, you're gonna rate his or her symptoms or in three categories, which is green, amber, and red. So green is distress, but functioning intact, no immediate risk. So आप उसके साथ डिस्कस कर सकते हैं, उसके साथ जो है वो उस प्रॉब्लम को जो है उसकी प्रॉब्लम को जो है वो बहुत ज़्यादा एक्सप्लोर करने की कोशिश करें, और इसके बाद उसको जो है आप साइन पोस्ट कर सकते हैं कि अगर आप चाहते हैं कि आप किसी भी साइकोलॉजिस्ट के साथ कांटेक्ट करें, या किसी साइकोलॉजिस्ट के साथ मैं आपका कांटेक्ट करा देती हूँ, या मैं आपको उसकी तरफ रेफर कर देती हूँ. Second is amber. Amber relates to persistent distress, reduced functioning, no immediate scale. We haven't got any immediate risk. But for amber signs, if you are suspecting someone to be in amber category, then you're gonna definitely signpost him or her to the psychologist. And third is red. So red is the urgency and risk, which we will be doing specifically for suicide and self-harm individuals. So for green, which we are categorizing as mild, link will be your decision point. So for green, you're gonna support, listen, and monitor. For amber, आप support करेंगे, monitor भी करेंगे, and then refer to the appropriate services. And for red, escalate immediately and ensure safety. For red, you will not be like delaying anything. आपको फौरन से जो है वो escalate करना है to proper individual, like to a psychologist or a psychiatrist. And if there is a risk of suicide, at that time आप confidentiality को जो है वो breach करेंगे, और फौरन जो है वो जो भी आपके पास pathway है, जो कि आपने कोई भी pathway डिज़ाइन किया हुआ है कि किस तरह से जो है उस सारे रिस्क को रिपोर्ट करना है, आप फौरन जो है वो इमीडिएटली अथॉरिटी को रिपोर्ट करेंगे पर्टिकुलर रिस्क के बारे में, इफ सुसाइड और सेल्फ हार्म, टू एंश्योर द सेफ्टी ऑफ द इंडिविजुअल. सो बेसिकली look, listen, and link, they are not related to diagnosis, but we will be using it to decide the safest next step. हाई रिस्क इंडिकेटर्स क्या हो सकते हैं, जो कि जिन्हें हम रेड इंडिकेटर्स कहेंगे, और जिन्हें हम रेड जो है उससे लेबल करेंगे, वो हैं सुसाइडल थॉट्स और इंटेंट, डिस्क्लोजर ऑफ सेल्फ हार्म, और अगर आपने ऑब्जर्व भी कर लिया है कि, और अगर आप ये सस्पेक्ट भी कर रहे हैं कि पर्टिकुलर कोई भी इंडिविजुअल जो है वो सेल्फ हार्म का जो है वो हो सकता है. What is the point of living if a student comes to you saying this and I don't want to continue? If there is any risk present, a minor risk present, then safety comes before confidentiality. What is the most important part of psychological first aid is the supportive communication. So if you can just write in the chat which response will be more supportive, you will be fine, or B, that sound difficult, I am glad you told me.
We are getting answers. Most of them are B. Nabga?
Yeah. Yes, I can say it. And
Okay.
that's absolutely
Maka.
right. B is the most appropriate and the most supportive answer. So a good practice for communication will be calm tone, using open questions. Don't use leading or loaded questions. Leading questions will be आपको कहीं suicidal thoughts to nahi aati. This will be a leading question.
If our
Loaded question.
participants
Like,
are international, please keep the language English.
okay. Loaded questions could be like you are asking too many questions at the same time, and then minimizing statements. Minimizing statements could be like you will be fine, you are perfectly all right, this happens to everyone. Boundaries. What are the boundaries of a psychological first aider? So your role is to notice stress, respond calmly, listen supportively, assess immediate concern, and connect to the student help. But your role is not to diagnose, provide therapy, promise secrecy where safety risks, take sole responsibility for the student well-being. Clear boundaries basically protect both the student and the staff member. Otherwise, you yourself will start feeling overburdened. What is a golden response formula, or when you like encounter an individual who requires a psychological first aid and you have to respond? So there is a golden response formula, which is acknowledge, validate, support, and refer. So according to the golden script, how are you going to respond to the indicators we have discussed before? So for green, you will acknowledge that sounds stressful. Validate, that's understandable, or I can understand what you are going through. Support, how have you been coping? What strategies have you been using for coping to this stress? And then refer, support is available if needed, and then closely monitor. For amber, you will acknowledge like, I can hear this is affecting you. Validate, anyone would find it difficult. Support, I'm glad you told me, and now let's connect you to the support. For red, acknowledgement will be like, I'm really concerned hearing this, and I'm really concerned about you. Validate, that sounds incredibly difficult. Support, you are not alone. And refer, we need to get help now. Always avoid these kind of statements. You will be fine. Others have worse issues than yours. Just relax, giving quick solutions that, and never like assure any kind of solution to a particular individual. Like you're gonna say, I can solve your problem, or I'll do something to solve your problem. That could be a false reassurance on your side, and that can worsen the situation. Instead, we'll stay calm. We will validate the emotions. That I can understand what you are going through. Listen actively, maintain boundaries, and encourage help seeking. That if you are if a student comes to you with a mental health issue, always encourage help seeking. That if you want, I can refer you to the psychologist, or you can go to the psychologist yourself and seek help. Refer and escalate as required. Document and report is really important. So if a student is coming to you with any mental health problem or any issue, please document and report. Specifically document everything. It will help in the later. You don't need to fix everything, but your response can change everything. Referral and follow-up. For referral and follow-up, we'll be doing escalation, when to escalate, who to contact, and there needs to be an emergency pathway in every organization, linking to support, linking to the counseling services, well-being teams, crisis helplines, if there are any, and then follow up. Brief check-ins, documentation, as we have discussed before, and maintaining appropriate boundaries. What are the common mistakes? The common mistakes to avoid are jumping straight to the advice, minimizing students' feeling, trying to fix everything, which you can't or we can't, asking too many questions too quickly, becoming over-involved and delaying escalation when risk is present. A supportive, contained response is more helpful than an overly complex one. Meanwhile, your own self-care and your own well-being is really important. So recognize your own emotional responses, debrief appropriately when needed, know your own limits. So if you are going through, suppose you have lost someone recently, and a student comes to you, and that particular individual has lost his or her significant other, and he is distressed about that. At that time, there is a possibility that you yourself starts feeling more distressed, or there could be a flashback of memories, and you might start experiencing negative emotions. So at that time, you need to know your limits. So you can refer that individual to any of your colleague. Seek support from colleagues or systems. Remember that you are not responsible for solving everything alone. Supporting further
Excuse
is
me,
also
Nabha.
self-awareness. Yes.
People are saying in the chat that your screen is not moving or the next slide is not there. Is this the same slide you are describing, or you have gone far?
What the slide is, sorry.
Do this instead. The title
Around
is
the
Do
to-do
This
list
Instead.
listed. Stay calm, listen actively, validate emotions.
Okay. Do this instead. I have moved 2 slides. I'm moving it and it's moving on at my end.
Reshare, please.
Okay.
Can you restart and then reshare?
Are you all able to see it now?
Yes.
So shall I get back to the previous slide?
So just do the full screen.
Okay. So that was the next slide after do this instead.
It's okay.
Okay.
If you have described, you can move forward and go to the staff self-care. Yes, this one.
Are you all able to see it now? Okay, seek
Yes.
support from colleagues
Yes.
or
Yes.
and
Yes.
and remember that you are not responsible for solving everything alone, so you can take help. Supporting others also require professional self-awareness. So key takeaways from my presentations were distress among students is common. Staff are often the first point of contact. Psychological first aid is about support, stabilization, and connection. The core approach is look, listen, and link. Use the traffic light model to judge level of concern and know when to support, when to refer, and when to escalate. You are not expected to be a therapist or to provide a proper treatment protocol that is required for a individual with mental health issues, but you are expected to be the safe first responder for a particular, if a if a student comes to you with, or a patient comes to you with some mental health issue. Final reflection is, how confident do you feel now after responding to a distressed student? And one key takeaway from this session.
मैंने आपको मना किया ना।
Thank you so much, Dr. Nabga. Very nice presentation, and we'll start question answer session. There are so many questions on this important topic, and I will request Professor Saima Batul.
Thank you, sir. Nabga, can you please stop sharing your presentation so that I can do? Thank you. Thank you so much for to Professor Mulazim Bukhari
आपका
and
शुक्रिया
Professor
डॉक्टर
Salma
साइमा
Aslam
बतूल
Kundi
आपका
for giving us this opportunity. I am Professor Saima Batul Naqvi, and I am a professor of pediatrics at University College of Medicine and Dentistry, the University of Lahore, and also uh, a medical educationist. And I have been supervising medical education students, masters, for the last almost 10 years. And I'm also the director of continuous professional development, CPD activities of Medical Women Association of Pakistan. This is my brief introduction. I was asked to tell the perspective of a pediatrician regarding the psychological first aid. But before starting, I will just have 1 or 2 minutes to specially thank, you can say, the stalwarts of medical education who are here, especially my teacher, Professor Lubna Beg. Thank you so much, madam, for joining, for giving so much time. I want you to, I request you to just give few comments regarding the topic, because I know it is, you are very much interested and a very senior person in qualitative studies and educational psychology. So can you please share your comments before I start, madam?
Thank you very much, Saima, for putting me on the spot. I was just learning something, and I did. I think Saima Rafiq's presentation was amazing as well. I learned a lot from Nabga. I think, given the present situation across Pakistan, this is something where we really need to talk about psychologically safe spaces, not only for the student, but also for the faculty. So that is why I especially appreciated when Nabgha's one of those slides, she talked about, when we are listening to everybody, we have to be cautious of our own internal psychological environment at the same time, and we don't realize that the most neglected people are generally the faculty, because there's a lot of expectation and not much given to that. So I think something that I'm trying to work on right now with my students is how to build that resilience. Saima talked about in the beginning, and of course, I am way before all of you. In my times, the more stress was given to us during our MBBS, during our residency, particularly residency, especially if you're doing at places like AKU, it was expected the more stress is given, the more we are going to learn, no matter
Yes.
what was happening inside us. And some of us were married with children. So it was so taxing for us that we were unaware of our own emotions. And then, it's more like some of those people, particularly of my era, still believe, which is so wrong, that they're going to learn. The more stress you give them, they're going to learn. That is so wrong. Yes, you have to make sure that the students are resilient and be able to manage stress. Giving a little bit pressure on how they need to learn how to learn. At the same time, we need to manage how Nabga has described, the PFA and how to look, listen, and link and things, those kinds of things. So, and some of us are doing that. So I think kudos to all of you, particularly having this webinar at this time. I was, my CHR had ended early today, so I was with that. And then I saw this message from Saima. She said, no, please join. And I'm so glad I joined. So thank you very much, Dr. Mulazim and Saim, my two lovely girls, Saima Batul, Saima Rafiq are there. And of course, Nabga, you are, of course, another same person. And thank you so much. I really appreciate doing this. There's lots of research with intervention needs to be done. So I think that should be our next target. So see you all next week when I'm again in Lahore.
Thank you.
Thank you so much,
Professor
madam.
Lubna.
Thank
You
you.
are also my teacher, and you really, when I was I student, the stress was actually no doubt every students and every time there. But from the stress, I learned so many things due to this stress. And I think stress, if any student take in a positive direction, I think it is better, as Professor Lubna you told us. But I do not know how people are here. We will discuss because Dr. Zafar Tanveer is here. And due to
sir, can I
topic,
proceed? We can
the
have the
incidents happened in his institution. That is an example. At the end, we will take all these questions and answer. Dr. Saima,
Thank you,
over
sir.
to you.
Thank you, sir. My presentation will be brief, so just bear with me for next 5 to 10 minutes maximum. So I have to give a pediatrician's perspective. And of course, as I am a medical educationist, so the touch will be there. So regarding the children, psychological safety is, you can say, much more important because children, they are not able to describe their problems as much as the adults can do. Like our medical students are adults. So as a pediatrician, I come across these problems much more. And as a pediatrician, I have, and all the rest of the pediatricians, there are few pediatricians over here who are among the participants. We have to put extra effort to just identify whether this child is having just a disease or is this complicated with the psychological problem as well. So this is basically a crisis. It's in a child, it is always not always loud, but maybe silent. So we have to pick. If you imagine a 7-year-old child, a parent or a medical student suddenly starts crying when I am in OPD, what will be the first sentence I would say, or you would say first? What will be the first sentence that you would say? Can anybody share? Any one of you? Anyone among the participants? What is the first sentence? अगर कोई रोने लग जाए, the child or a parent or a medical student or anybody else comes to your office and starts crying suddenly, what will be your first sentence? First sentence to that person?
I will say, please have a seat, and I will offer them a glass of water, and then
Yes, you are a psychologist. Yes, you
Yes,
will do that. I know. Anyone else?
I think what the teacher will ask. So many teachers are there.
Yes, you
Usually
can
the
tell me
students,
the teacher's perspective as well.
such incidents happen with the students.
अस्सलाम वालेकुम।
जी डॉक्टर आमना शाह।
सर मेरी प्रैक्टिस तो यही होती है कि जब अक्सर औकात बच्चे इस तरह स्ट्रेसफुल कंडीशन में आते हैं तो सबसे पहले तो हम उन्हें बिठाते हैं, उनकी सारी बात सुनते हैं कि हुआ क्या है। Particularly they are more concerned with the marks nowadays. The students are going with the mark that they should be having a good GPA, they should be having a first position. So always I request them that position holder remains the one, and don't go and don't run with the GPAs. Study doesn't mean that you will be having a good GPA. It depends upon the skills. To develop the practical skills so that you may be live in your future.
Thank you, Dr. Amna. Now proceeding with, because we may be short of time, so what PFA is or psychological first aid is and what is not. Dr. Nabga has given you a brief overview of the this proper PFA concept. So I want to reiterate and reaffirm her that PFA is not psychotherapy. It's not a diagnosis and not forcing someone to talk. It is basically a calm, safe, practical first response after distress. And WHO has said that this is basically, as we know that first aid has to be every person, even if he is not a medical person, should be well versed with the first aid. So do the psychological first aid. So WHO has said that PFA guidance emphasizes supportive and practical help after serious crisis event. So you do not have to preach or do not have to force anyone to talk. Just wait and see and follow the 3 steps which the Nabha has told you. Similarly, we do it in children. And when we look at the global perspective, the global child health and psychological first aid evidence, if we look at it almost throughout the sphere, starting from the north till the south, the different medical societies as well as the societies which are associated with the psychological problems, they reiterate that the psychological first aid is the mandatory skill which a person should know, a person should listen. And one of the things which I come across, which was new for me, that this concept of I was given of look, listen, and uh, link was given by the International Federation of Red Cross along with the WHO, and in the UAE and Middle East, they have labeled it as 800 Sakina. Sakina is the name given to it, and they said that they have made it, you can say, their helplines in which whenever a child with a psychological first aid is received, that particular helpline can be used to report that child with some psychological distress. So look, listen, and link apply to not only to the adults but also to the children. Same case which from which we started, that a 7-year-old child after an accident is quiet, refusing to speak, tightly holding the mother's dupatta, comes to your OPD. What do you look for? Yes, we look for safety, physical safety, because after the accident, he may have some sort of trauma. So look for the safety and injury. Look for the caregiver presence, whether there is a caregiver along with the child or not. Then his immediate needs, he may look thirsty, he may look hungry, or there may be some degree of distress. So this is the first thing in a child to look for, because most of the time children can't speak for themselves. In the second thing, if we apply it to the same 7-year-old, what we have to listen? We have to be all ears, because if I say, if I have just ensured the initial safety and looked at the uh, safety of the surroundings of that child, what will be the first better sentence out of these two? Can anybody tell? Will you say A, don't cry, everything is fine? Or will you say B, I can see this is very difficult, I'm here with you? Can anybody of you, very easy, which one will you choose? Anyone from the participants?
B.
B, very right, thank you. B is the safest, B is the best option or the better option out of these two, because children, they may won't stop crying just after
Is
saying
this
that
a
don't
part of
cry or everything
empathy,
is safe.
Dr. Saima? Is this a B is
It's
like
not part of
empathy?
empathy, sir. You can, yes, a bit of empathy you can say, but it's part of the active listening, basically. Active listening is a process itself. So active listening is just not sitting in front of a person and listening whatever he's saying. It is basically an active process so that the other person understands, or by looking at you, just by looking at you, that you are all ears. You are not using your mobile or looking at some the child is talking, and if I am looking at some other area or some other side or writing something, that person or that child will not be able to share his or her experience with me. So that is the active listening. And last one is the component of look, listen, and link. For this child, we have to look for certain red flags, and we have to avoid, for example, if we find that there is a self-harm talk, like Nabga has said, we have to categorize that particular child into the red category. अगर वो कहे, if a child says that I am going to kill myself, even the small children, they do talk like this nowadays. So that is another thing. So this is the child who has to be kept in the red category and referred as early as possible. So if we combine all these, it's, you can say, the psychological first aid, 3L, or look, listen, link, is basically an early, humane, practical support for a child. And children, as just a summary, that children do not always say I'm distressed. You have to look at it's just like um, uh, this iceberg. You don't have to see the tip. There are many things which are under the water. So we have, as a pediatrician, we have to look for these as well. You are safe. I am here. Take your time. These are the things we usually say to children. What will you do first? Ask detailed questions now. After 1 minute has gone, the child has taken deep breath. We can ask, and we do ask like this. Tell the child not to worry, sit calmly and ensure safety, and call the parent irresponsible. Out of these, the which one will you choose in the first minute? लिखा हुआ है वैसे तो आंसर is already there, the C answer. Sit calmly and
Sit calm and
ensure
ensure safety.
safety. Yes, thank you. And also look that if
Thank you,
the
Arif.
parent or the caregiver is distressed, so we have to keep it in mind as well. So psychological safety prescription for a child is not for it doesn't contain any drugs. It contains certain words which reassure that the child will think that he is safe and he will be taken care of. And as we know, that child abuse and child neglect is itself a big field, evolving field, still evolving in Pakistan. And we have various child protection agencies across Pakistan, and also different NGOs working. These are the references which I have used for my presentation. Thank you so much. And
Thank you so
my
much, Dr.
email is mentioned.
Saima
If
Batul.
any questions and any comments are
Yes.
here,
Before
I will
starting
be
question
there.
answer, can I ask Professor Aisha Humayun? You are a leader of one of the institution. Can you give a few comments about this? Then we'll start the question answer session. Professor Aisha Humayun. I think anyhow, so many stalwarts are there, and now it's the session open for question answer. So my first question to the Dr. Nabga to you is that let me know how the students reach at the stage of emergency, and why the students reach at the stage of this emergency, because in last 2-3 months consecutively, I am watching and I am writing on the suicides of medical students, and I think the fault, 100% fault lies in the students. They did the suicide, but reversely, on contrary, they blamed that the teacher are involved and the teacher were making the harass. Let me know, give the answer of this, Dr. Nabga, to you.
Thank you, sir. Thanks for asking. So there could be a number of factors, including burden of studies, but that could not be, we can say, the principal factor for suicide for any student. The thing is, if he is, regardless that if he is a lot like vulnerable, or he has got a vulnerable personality, or like who gets distressed easily and who like gets anxious easily, then there is a possibility that solely studies could be a burden for an individual and it can lead to suicide. There could be a lot of other factors which, like Dr. Saima Batul and Dr. Saima Rafiq, they both have discussed that there could be a lot of factors that, including family dynamics, social media is the most important thing. What I would like to add and to their discussion is, like, now at social media, suicide has been, we can say, we have like fantasized it. Like if you watch some dramas, suicide is being fantasized in a particular drama or in a particular novel. The suicide has been, I have read a lots of novel in which they have presented suicide like a complete plan, like a fantasizing plan. So these all things can impact, these all things can aggregate, then can join together and can become like a preceding factors for a particular event. And then there could be an event of, like, suppose the student got failed. So all these previous factors, all these, or we can say all these previous stresses, like will combine to will get combined with that particular stress that he's facing at a particular time, and then it can lead to a like self-harm activity like suicide or an attempt to suicide. The studies won't own, like, if we cannot like categorize educational burden or teachers as the sole responsible for a self-harm activity.
Okay, thank you so much. Dr. Ali Mansoor, you have raised the hand. You can ask the question, Dr. Ali Mansoor.
Thank you very much. Assalamu alaikum. This is Dr. Ali Mansoor from
Thank you.
Iraq, Karbala. I'm very glad to be here. I'm sorry to be late to be joining
No, because you are also leader of one of the university, and thank you so much for joining us. Dr. Ali Mansoor is the professor of in Karbala and very good teacher. Professor Ji.
Thanks. Thank you very much. I'd like to thank Dr. Nabga and Dr. Saima. My question is for Dr. Saima about the red flags in children OPD. I was wondering about alarms to make ourselves thinking about red flags, and can we consider ADHD signs as one of alarms of a red flag or an emergency in this condition? Thank you very much.
Thank you, Dr. Ali Mansoor. Thank you for joining us and putting forward a very important question.
From Varis University.
Yes, he is professor from Columbia University, Karbala, Iraq. Thank you so much.
Chair of DME.
Thank you for your question. There, you are right that many a times when we come across children with these red flags, we have to keep it in mind as our differential diagnosis that this child may be a case of autism spectrum disorder or maybe a case of ADHD. These two, they are two separate, you can say, and sometimes they occur together as well with the big features which intermingle. So whenever, as a pediatrician, we come across any sign, for example, the child is not making an eye contact, or if the mother or says there will be a history, if the child is a case of autism spectrum disorder, there may be a history given by the parent or the caregiver, whoever is accompanying the child, that this child does not make eye contact, is not able to speak properly, give answers to that, or there may be other signs that repeating the words which are being told or which are being asked for him. If, for example, if a mother says, bring a cup, the child will be repeating that sentence, bring a cup, bring a cup, bring a cup, repeatedly. This is called echolalia. So there are many other signs. There is a full length of signs. Nabga deals with such patients. Not only she has been dealing here in Pakistan, but also there as well. So she will be better describing it. So, but you are right. Many a times, if the distress is because of the underlying problem like ADHD or ASD, we have to keep it in our differential diagnosis. We have to go for certain, you can say, criteria checking. It had a DSM-5 criteria, and we refer these children to the pediatric psychiatrist and pediatric psychologist. Over to you, Nabga.
I would like to add some bits into your discussion, Dr. Saima, that for children with ADHD and children with autism, they harm themselves to basically regulate their emotional needs or that they are going through. Just like it will involve biting, it will involve like scratching their skin, and sometimes it will lead to like excoriation disorder, and then it will like obsessive hair picking, which we call trichotillomania. So these all could lead to suicide in the later age, or they can like harm themselves without the intent of suicide. So yeah, you are right that we need to like look on these things as well, these factors as well, because autism and ADHD is getting common now, and it needs to be diagnosed early and as early as possible so that we can help a particular child. Because when I like came across with the lots of children in my school and in Pakistan as well, who literally they bite themselves, and they have like literally took their skin off while biting, and they have like proper signs of biting on their skin. But for that, like for this, we need to like list, and this will also help us like to differentiate that whether a particular individual is doing self-harm, or it's if it's he or she is going for like emotional or self-regulation. Thank you very much.
Sometimes we have to differentiate it from the child abuse it as well, because many a times child abuse
Yes, this
is
is
by
exactly what
the
this is
caregivers
exactly what I
themselves.
was
Many a
trying
time.
to say. Yes, thank you
Yeah,
very much. This is the exact idea I was just want to say it. Sometimes there is overlap, and sometimes there's
yeah.
combination of ASD and abuse, and maybe one of the causes of abuse is the ASD, and the parents are not, يعني, are not considering this as a diagnosis. They are just um, um, reacting wrongly toward the child and make him suffer from child abuse. So we must pay attention for that side, because this may be missed as an ASD, and maybe as suffering by his parent or caregivers. So I think this is very important to be look for during this case. Thank you very much.
Thank you. Thank you. Professor Saima Rafiq, I have a question for you.
जी
Okay,
जी
let me know what you are looking the increasing trend of suicide of the medical students in medical institutions. If you take the review from the last 1 month, 6 months, I think 2-3 incidents have been happened. One in Sindh, one in KPK, one in Punjab. What you are looking, how and what will be your suggestion as a teacher? Because
Mulazim Sahab, I think it's a more than 4 to 5 cases during these period
4
which
to
you
5
have
cases.
mentioned.
Yes, 4 to 5
Yes.
cases. Kaisa Sajad? Yes, 4 to 5 cases. That is why, because she is a teacher, I think, and not only a educator. What you are looking, this trend in the medical students are increasing. And today's webinar, I think, what message can we give to the parent, to the teachers, and to the students?
Okay, thank you so much, sir. Sir, in my personal opinion, one thing that went wrong was actually that I guess Nabga did touch that, how to handle the case of a suicide. We
One
have
question
to
is
look for
add the Dr. Saima, add the one more question: verbal abuse from faculty member. Though such faculty members are very less, but sensitive students can. Yes, Dr. Saima, you will address this question also.
Okay, so what I feel was that while we have these cases that they came on media, there would be some cases that do not came on media. So the first thing which I personally feel was a very respectful and careful role of social media, and that do include the questioning and how it should be posted, and how the university should handle that cases. And plus very, you can say that it should be you can say very careful, where I don't know what can be the right word for that journalism. One thing was that. Second, I do feel, and this would be linked to your question, second part of your question, I feel that now we should learn one thing, and that thing is, if I cannot disrespect my 5-year-old kid, how can I talk to my 23 or
Yes,
22 years
yes.
old student in the same tone? We need to learn that. There is no second opinion in that. You cannot say this is the thing, that you cannot even say no to a 3-year-old son that can come up and say that, mama, you were disrespectful to me. How can you do the same thing to a 21-year, 22 or 23-year-old student? We should be very mindful. We are teaching Gen Z. We have to learn the slang of Gen Z. We have to learn how to deal the Gen Z. It doesn't mean that we are not we should be very strict teacher, and the strict teacher would be very, you can say, successful teacher or so, but you have to learn them. The problem is or the trick, or you can say the tip is, you just need to learn 2 or 3 things as a teacher. One, you are dealing with adults. Adults need to be respected, so your communication should be very respectful. Number two, these are all visual learner. They have seen mobiles and screen in from the womb, so we cannot separate this mobile phone, this social media platform from their lives. It's just how we can give them a better option to use this social media platform. So maybe you can design an assignment that may be linked to the screens or so. They have to use the social media platform, so we cannot separate it. And number three is that I don't know, but I personally I can say, I cannot generalize it, but personally I do feel that I have some role in their lives with very basics of spiritualism, that you can tell some of the norms of spirituality, because we are living in a global world. There is an influence and influx of these K dramas and Japanese drama and all that, and I just have a visual aspect of these drama just to have my opinion, what's wrong with them, or what's in these drama for our generation. So they have see, their belief is different. they say that you can go for a suicide, and this will release all the sufferings and all that. So we somehow, I don't know, I can generalize it or not, but I personally, for me, it works that you can just come up with the very basics of your religion or even spirituality, and that can actually help and that can work.
So
Maybe
much,
I have
Dr. Saima.
answered it.
Before we conclude today's session, I will say one एक शेर मैं कहता हूँ
जरूर.
कि ले सांस भी आहिस्ता के
नाजुक है
नाजुक
बहुत.
है आफाक की
बहुत
कारगाह है शीशा करी का. But as a teacher, what I am looking from the last 10, 15 years, as a Muslim, we teach, our students are more believing on the social media. And if we start your comment was spirituality and religious belief. If we ask the students to recite the Quran with translation and what the Allah is saying to the human, that don't be, वो कहते हैं ना उम्मीद वबस्ता रह शजर से उम्मीदें बहार रख. I think these all things the teachers must. हमें भी थ्रेट मिला करता था. नो डाउट हमारे पास तो इतना बड़ा डंडा होता था फॉर माई teacher to beat me when I was in fifth, fourth, third class. So anyhow, these are the things. I think my message is that we should also include our students. They should learn the Quran, and if they are not Muslim, they learn their own religious books, Bible or something else, and but with translation.
I
Thank you
guess
so much.
harming the life is almost same for almost all,
Yes,
every religion.
almost. Belief of the Allah is that. Because when we say that Allah is very close to this carotid artery, and
Yes.
if our students believe this, that my God, my Allah Almighty is always, and when I say everything to my Allah, I think these incidents can be reduced. Professor Salma Kundi, over to you to conclude today's session. बहुत ज़्यादा time
डॉक्टर
जी जी.
कोई कमेंट कर सकती हूँ?
Thank you
If
so much.
yes, Aisha Humayun,
Yes.
I requested you. Yes, Professor Aisha. Thank you so much for joining.
Yeah, sorry for joining late.
नहीं,
Very well
आप तो उस्ताद हैं
concluded.
ना, लीडर भी हैं, आपको तो ये इम्पोर्टेंट. जी जी.
I just want to share my experience. Currently, I have started working on training students for psychological first aid, to impart psychological first aid to their colleagues. इसमें थोड़ा सा मुझे ये फ़ायदा हुआ कि जो मेंटली हेल्दी और जो इस तरह से जिन स्ट्रॉन्ग स्टूडेंट्स हैं विद स्ट्रॉन्ग नर्व्स, हम उनको ट्रेन करते हैं ताकि जो पॉजिटिव डेविएंस का एक कॉन्सेप्ट है कि अगर हम स्टूडेंट ज़्यादा इम्प्रेस होंगे, ज़्यादा अच्छी तरह से उनकी बात सुनेंगे इफ़ दे आर फ्रॉम देयर ओन सर्कल. So students can provide psychological first aid to their colleagues, to their class fellows, as compared to teachers. Because we have just one psychologist and one psychiatrist in the entire hospital. So they are, we don't have a human resource to actually cater 500 or 1,000 students. And we are from a different generation. We cannot understand what they are feeling. So this time I have started working on training students for providing psychological first aid.
Yes.
And then they can pick them. And another project that I'm working on is providing training of trainers on psychological first aid to work in flood affected areas. In this year, again, we are expecting 46 districts to be involved in flood. Allah na kare, but this is the prediction for the 2026, that there will be more, flood. So that's why I think such kind of training on psychological first aid is important, because mental health is more important than physical health, and it actually determines the physical health. So thank you so much,
Dr. Aisha. Dr. Aisha, I agree with you, because before performing the suicide, that students tells this thing to the colleague. That is very important. That is very important. If the colleague is stronger nerve, she and he can stop it. This training should be started in other institutions. to make this training so that we can reduce the number of suicides in the medical student and the failure. Even in the failure, not some people perform the suicide, some people leave the institution, and these are the things that are leading with the failure of the medical
Thank
student.
you, Dr. Mulazim.
जी,
आपकी आवाज
शर्मा कुंदी
हो गई है.
This is the tip of iceberg that we are seeing.
Hello,
There is
Assalamu
a
alaikum. I think all of you who are present here today, Dr. Aisha Humayun, that's such a good concept. In fact, I will introduce it in my college as well, where the students will be trained to help each other. Thank you so much. My special thanks from this platform to both Saimas, Dr. Saima Batul, as well as Dr. Saima Rafiq, and to Dr. Nabga. They really gave us some good food for thought in their participation on how to prevent mental illnesses and to sort of find out whoever is prone towards suicide or self-harm. I hope we all try to help these students and we pick them up and we try to instill resilience in our students. They should be resilient, and I agree over here that spiritual benefits and their spiritual inclination will make them more resilient, inshallah. I thank everybody over here who's present today. You've given us time on your weekend, and thank you very much for that. And I hope you have a
clapping
great
for the
weekend.
speakers.
Yeah.
Thank you.
Thank you.
Thank you so much.
Well
Thank you
done.
so much.
They're great speakers.
Th-
So
Thank
that
you.
is it for today. Thank you.
Thank you, madam.
Thank you. Have a great
Thank you, ma'am.
weekend. Allah ke hawale. Allah
Allah
Hafiz.
Hafiz.
Pakistan
Thank you,
Zindabad.
Dr. Afroz.
Allah
Allah
Hafiz. Thank you,
Allah Hafiz.
Rahma.